Our next speaker is going to be Alejandro Filloy, who is going to talk to us on subliminal laser for center-involved DME. Alejandro, it's all yours.
Good day. Thank you, Doctor. It's a pleasure to be here. And I'd like also to thank you, Quantum Medical, for making it possible one more year, considering the circumstances. So let's talk about practical uses for subliminal laser regarding the center involving, which by that I mean fovea involving diabetic macular edema. When and how? Let's start by when. I mean, or perhaps we should start by why. I mean, we have a lot of options today to treat center involving DME. We have a variety of intravitreal agents, anti-VEGF, steroids, and so on, which are effective, powerful, and relatively safe. Well, we should consider laser because there is a lot of diabetic patients who present in a lot of different manners. And in certain clinical scenarios, more than a few, in fact, a weak laser treatment is all you need to control the patient in a safe, effective, and efficient manner. Let's not forget that the intravitreal option has a relatively high cost and a portfolio of complications, which, although unusual, are quite important when they happen. And which are these scenarios in which laser may help you in your center involving DME? Well, scenario one is not a center involving, it's a clinical significant extrafoveal edema, which Christine has already spoken about very handsomely, so nothing more to add about it. The scenarios I'm going to talk to you are the ones to follow. First, combination treatment, and the fovea involving mild edema. Let me tell you what I mean by each of them. First of all, the combination treatment or after intravitreal injection. We all know that when the fovea is involved and the vision is decreased, you want to remove that edema fast. You want to free the fovea from that inflammatory environment, so the long-term prognosis for visual acuity is better. So it's an option you have is just to remove all the edema and keep injecting until it's resolved, and then watch for it to recur, or you can first inject until the fovea is rescued. You allow me to work, like in this situation, you inject and then the fovea is much better, all is way thinner, so you can then laser the surface, the remaining thickened area, and this obtain a more durable response with just a single injection. Third scenario would be when the fovea is involved, mainly visible on the OCT, but the patient remains asymptomatic with very good visual acuity. Here things get more complicated. I mean, should we just observe this patient, risking a deterioration? Should we inject them, risking a complication? A 20/20 eye surgeon and endophthalmitis is no little thing. Of course, no one I hope would use normal laser in this situation. We are very close to the fovea, but we have a third option, which is subliminal or subthreshold laser. As we can see in this case, we can treat this area so close to the fovea without any repercussion of the RPE, and we observe a slow resolution of the edema, which is maintained week after week, visit after visit, the following months. Each slide is separated 12 weeks from the previous one. So as you can see, with a single treatment, we usually obtain a good and durable response. As you can see, in comparing the autofluorescence imaging, there is no disturbance of the RPE. More complicated cases with a little bit thicker maculations in this case, or even an initial neurosensory attachment will also respond well, as you can see. Even thicker case with also peripheral thickening, you can treat the whole area involved. 360 thickening, you can treat the donut shape, the fovea, you obtain this nice response, still a bit thickened, but no cyst remaining, so the disease has been taken back a few steps, so you obtain a greater degree of control over it. As you can see, this is an after treatment image no spots visible. There's about 400 spots under this retina for treatment. None of them are visible. It's good to ensure that spots are non-visible, as Dr. Wu said earlier. Regarding this particular scenario, we recently have conducted a small study. We have found in a group of patients a significant decrease on foveal thickness both at the first visit after treatment and a long-term, and a partial or complete resolution of DME and the OCT in the majority of patients, while the excellent visual acuity was maintained. We found then threshold subliminal to be effective and safe for these patients. We have also used a fovea sparing technique, not treating it. I will talk more about it later, which doesn't seem to jeopardize the results. And although current literature suggests observation to be a reasonable treatment based on the protocol V findings, we must take into consideration that protocol V observed the patients in a clinical trial degree of follow-up, so very often and very closely, difficult to do in real life. And remember that 1/3 of that group of observed patients required intravitreal injections during the 2 years of the study. So the rate of worsening is quite high. And of course, they didn't use subthreshold in any of the comparison arms. If you are more interested in our study, it's been recently published. It's an open access study, so it's readily downloadable from PubMed. Second, how is it done? How do we perform this subthreshold laser for central involving diabetic macular edema? Well, we will follow the guidelines Dr. Wu has already provided. It's important to treat a large area because you need to stimulate a number high enough RPE and Müller cells to obtain a clinically significant response. And for this very same reason, you need to treat it densely. From the area you choose to treat, be careful not to leave any blank spaces so you recruit any cell available to work for you. Of course, you have to use the appropriate power, especially taking care not to use too much of it, or otherwise you will be using a supra-threshold treatment with cell damage, scarring, RP, hypertrophy, all the kind of things which are not necessary to obtain a clinically significant response, but are an undesirable secondary effect. Remember, insufficient spots has been identified as #1 cause for treatment failure. Should we treat the fovea? I copied this example, this animation from Victor, because I really loved it. Let's suppose you have this edema, which is involving the fovea from the temporal side. You want to treat this whole area. Using 160 micron spots, it would mean something like this. So you will agree with me that there will be hardly any difference between this treatment and this one, right? What I mean is the fovea is very small. It's only a few spots that take to cover it. So instead of using 250 spots, as you can see here, using 258 will hardly mean any difference. You can spare the fovea from the treatment. The beneficial treatment will spread to it from the neighboring treated area, and you will sleep better at night. Of course, transfoveal treatment has been classified as safe by the expert subthreshold practitioners, but if you are such an expert, if you're in your beginnings, I really recommend you to exclude the fovea. I assure you the results will be equally satisfying. Technical guidelines. For DME, I use OCT as a guide, 5% beauty cycle. I titrate at 33%. I found it my preferred percentage. Dr. Wu just recommended 50%. It's a little bit of a personal thing. I recommend you to start cautiously and then work your way up from there. I use 160 microns spots, and you have to treat large areas centered at the peak of the thickened retina. And I recommend you, at least at your beginnings, to avoid foveal treatment. After 8, usually around 12, 16 weeks, you will start to see results. And I recommend to check the OCT carefully to look for any RP disturbance, for which seeing the autofluorescence is going to be really helpful. So remember, laser is after all surgical technique, so your experience and patient selection is key. Surface area and density are the key technical cornerstones. you need more patients than the one we are used to have with intravitreal therapy. You need 6 weeks for central serous and 8 or 12 for DME to see results. And as with any surgical procedure, audit your results and yourself, you will be getting better with time. That will be everything. Feel free to write me for any consultation you may have. Have a nice day. Thank you.
Thank you, Alejandro, for sharing your experience with us. Very enlightening.